Hi friends, today I will talk about hypertension mediated organ damage. First is the disclaimer. Caring Docs YouTube channel does not provide medical advice. Information available on this channel does not offer diagnosis or advice regarding the treatment. Information provided here is for the educational purpose only. It should not be used as an alternative to healthcare professionals' diagnosis or treatment of any person or animal. Please seek the help of medical expert for diagnosis, prevention, and treatment of medical illnesses. There is no endorsement for any brand or a company. As we know, hypertension is a silent killer. It affects 15 to 40% of the people worldwide. It is often asymptomatic, so many cases they go undiagnosed. Diagnosis is very tricky as patients with hypertension they usually have no symptoms in early stages. So detecting complication is even harder and it needs detailed clinical examination and targeted investigations. Why early detection matters? Because hypertension can cause serious organ damages if it is not diagnosed early or treated early. The commonly affected organs are heart, brain, kidneys, and blood vessels. How the hypertension affects the heart? It increases the afterload. Heart has to work harder, and this leads to left ventricular hypertrophy. Initially, this phenomena is adaptive, but over the time it becomes harmful. The patients with LVH they develop complications like diastolic dysfunction, in which the ventricles they become stiff and there is poor filling of the blood. The patient may have myocardial ischemia due to obstruction in the coronary blood flow or less blood flow to the heart muscles. Patients may have arrhythmias including the atrial fibrillation. And if LVH is not treated properly or if the patients with hypertensions are ignored, then these complications can lead to heart failure, and this heart failure can be heart failure with preserved ejection pressure or heart failure with reduced ejection fraction. The clinical signs of left ventricular hypertrophy, which we can see on auscultation, are heaving apex beat in inspection, S4, that is the fourth heart sound, loud A2, and ejection systolic murmur. The LVH can be easily diagnosed in the ECG by there are various phenomena or various laws. That is, the important one are Sokolow-Leon criteria, coronal voltage criteria, and one very commonly used is tall R in lateral leads, that is lead V5, V6, and ST depression. It suggests the left ventricular strain pattern, though it has a low sensitivity, but when it is present, it has a high specificity. We can diagnose the left ventricular hypertrophy by doing the echocardiography of also the 2D echocardiography or transthoracic echocardiography. Here we can see the left atrial size, left ventricular wall thickness, ejection fraction, diastolic functions of the heart. In the last, the patients with LVH, we can see the fibrosis by doing the gadolinium enhancement cardiac MRI. So the when if the LVH is not treated properly, the patient can have features of the heart failure, and the initial examination in the heart failure is we see the cardiomegaly in chest x-ray. When cardiothoracic ratio is more than 0.5, we can see curly B lines, bat wing pattern. In echocardiography, if the ejection fraction is less than 40%, the patient can be said to have heart failure with reduced ejection fraction. Here the left ventricular is dilated also. The patient with Heart failure with preserved ejection fraction, they have ejection fraction of more than 50% or 50%. Here the left atrium is enlarged and there can be abnormal EA ratio. Biomarkers in the heart failure are NT-proBNP. They are elevated. These may be elevated in both heart failure with preserved ejection fraction and heart failure with reduced ejection fraction. They may be falsely low in obesity. There are emerging markers like ST2, GDF15, galactin, but they are under study and they indicate the risk of developing heart failure. Coming to the next complication due to high blood pressure is the aortic dissection. It is whenever it develops, it is always an emergency. Patient had a sudden tearing chest pain which radiates back into the back in the interscapular region. Uh, Here we find BP difference between limbs. We can see new murmur. The diagnosis of aortic dissection is usually by the CT angiography, that is gold standard, or we can do transesophageal echocardiography for unstable patient. The patients with in the if the patient if we do the chest X-ray, we will see widened mediastinum in patients with aortic dissection. Next complication of the hypertension is peripheral vascular disease. Long-standing hypertension usually leads to arterial damage. The patients have symptoms of claudications, ulcer, or gangrene. If we do the ankle brachial index, it is usually less than zero point 0.9. Doppler ultrasound and angiogram, they are helpful in diagnosing the peripheral vascular disease. Patient with hypertension, they can present with ischemic heart disease, which is very common. The hypertension increases the risk linearly. We should always ask the patient about angina, breathlessness. In ECG, we see STT changes, Q waves, ST elevation MI or non-ST elevation MI. If patient presents with acute chest pain, then these patients may have TROP-I or TROP-T elevations. These are the biomarkers for diagnosing MI. CT angiography, calcium score, coronary angiography is usually done for assessment to see any blockade in the coronary artery. Patients with cardiac failure, whether that is reduced ejection fraction or heart failure with preserved ejection fraction, they have symptoms of breathlessness, fatigue, edema. Clinically, they may have gallop rhythm, crackles in the bilateral chest. They may have elevated JVP or elevated blood pressure. The patient with acute heart failure, they can present with pink frothy sputum, hypoxia, and whenever these symptoms are present, it is an emergency. We have to treat it on priority. Coming to the effects of the hypertension on eye, we use this high blood pressure usually affects the retina, and it is very common in CKD patients. More than 80% of the CKD patients, they have eye complications. The patients usually have retinopathy, choroidopathy, optic neuropathy. The eye examination is usually done by fundoscopy or OCT. In fundoscopy, we find AV nicking, flame-shaped hemorrhages, cotton wool spots. The OCT the OCT detects macular edema, retinal thickening. And next is the fluorescein angiography. It shows microaneurysm, neovascularization in patients with hypertensive retinopathy. Another complication is the CKD. The patients with hypertension, they usually have kidney complication, kidney damage. There is a direct link between high blood pressure and kidney disease. The CKD stage 4 or 5 or patient with severe albuminuria, they have very high cardiovascular risk as per ESH guidelines 2024. Because of hypertension, There is nephrosclerosis. It could be benign or malignant. Patient will have elevated creatinine. Patient will lose protein in the urine, that is microalbuminuria or macroalbuminuria. And because of these changes, this may lead to fibrosis, tubular atrophy, and further progression of the chronic kidney disease. The risk factors for developing the chronic kidney disease depends on the duration and the severity of the hypertension, whether the patients with hypertension they have diabetes or they have use of non-steroidal anti-inflammatory drugs, whether these patients smoke or not, family history, polycystic kidney disease, pheochromocytoma, obesity, sleep apnea, Cushing's, they all contribute to further progression or development of the CKD in patients with hypertension. So, how do we evaluate? We have to check BP in both arms and legs. We can see we can auscultate renal bruit in suspected renal artery stenosis. We have to do urine albumin creatinine ratio, serum creatinine levels, and we have to calculate the eGFR. There are various methods to do calculation of the eGFR, and based on the eGFR, we usually categorize uh, the stages of the chronic kidney disease, taking into consideration urine ACR also. Renal ultrasound or Doppler, serum electrolytes, cortisol, calcium levels, these are all needed to be done in while evaluating the kidney damage in patients with hypertension. In patients with hypertension, we should always do urine ACR every 3 months. We have to check eGFR and creatinine every 6 months, and more frequently if the patient is non-compliant to the medication or patient has uncontrolled hypertension. How does the hypertension affects the brain? The patients with high blood pressure they can end up with ischemic stroke, transient ischemic attack, intracranial hemorrhage, or subarachnoid hemorrhage. Patient can have hypertensive encephalopathy, white matter changes, which leads to dementia. The intracranial hemorrhage is most common complication of a severe hypertension, and the affected sites are putamen, thalamus, pons, cerebellum. And the high risk groups are high risk categories are depend on age, uncontrolled blood pressure, alcohol, and use of anticoagulants by the patient. In hypertensive encephalopathy, the patient has sudden high blood pressure which leads to brain edema, and these patients they present with headache, vomiting, seizure, and they can end up with coma. MRI of the brain will show parieto-occipital edema, and which may lead to further Press syndrome. The patient with high blood pressure they can present with subarachnoid hemorrhage. Patient presents with thunderclap headache, neck stiffness, and it is usually caused by the rupture of the aneurysm. It may be we may see retinal hemorrhages on the fundoscopy. So the focus history of the brain is very important. Patient with transient ischemic attacks may have symptoms like seizures, headache. We have to ask about this transient ischemic attack history also, history of drug use, anticoagulants, and the symptoms of the stroke they help us in localizing the bleed site. So whenever the patient comes to us with stroke or ICH or SAH, the investigation of choice is CT and CCT head, and MRI is also done to rule out the brain hemorrhage. If the patient has seizure, we do EEG. Carotid Doppler is very useful to diagnose stenosis and intima media thickness. CIMT and PWB they measures the arterial stiffness, but these are not used routinely. Why early detection and prevention is best because we know that hypertension is often silent. Home blood pressure monitoring helps us to detect the masked hypertension. Ambulatory blood pressure reveals nighttime BP patterns. If we detect the blood pressure, lifestyle plays an important role. We should keep the BMI body mass index below 25 kg per meter square. Patients should be instructed to have low salt. They should limit their alcohol intake. They should eat dash diets, that is dietary approach to stop hypertension, means they should be encouraged to take fruit, vegetables, low salt diet. They should be encouraged to do 30 minutes daily physical activity. Potassium and calcium intake is good for high blood pressure patients because of if the treatment is started initially or very early, it has been seen that 5 of blood pressure drop shows 8% decrease in risk of ischemic heart disease, and the left ventricular hypertrophy regression is also seen with the treatment, and there is a risk of further stroke and mortality is decreased. Every antihypertensive group every antihypertensive group helps to reduce the hypertension mediated organ damage. So whatever antihypertensive we are using, usually they not only reduce the blood pressure, but this helps to reduce the organ damage. So follow up recommendations are, whenever we control the BP or we put the patient on antihypertension antihypertensive drugs, the initial control goal is achieved within 4 to 6 weeks, and the low risk group, they should be advised to visit once in a year. High risk or uncontrolled BP, they should pay 2 to 3 visits per year. Repeat carotid Doppler only if clinically indicated. These are the few references which have been gone through to prepare such slides. As a caregiver, you see selfless acts every day. With this, I conclude my today's topic. Thank you. Keep learning.